All right, well, it is noon, so we're going to go ahead and get started. So my name is Jordan Perchik. I am a radiologist at the University of Alabama at Birmingham. I'm thrilled to be here today to kick off the AI Literacy course with you all today. We have an excellent series of lectures and a full day today, so I'm going to go ahead and get us started. So here you can find my relevant disclosures. And so this is going to be our overview for the week. So we have a packed week. We have 10 lectures that we're going to be covering over the course of this week from September 30th to October 4th. For those of you that have been a part of our lectures or a part of this course before, you may notice that the schedule looks a little bit different this year. So each year we cover different subspecialties in radiology. So this year we're highlighting AI and MSK imaging, pediatric imaging, cardiac imaging, and nuclear imaging. And last year we covered body, chest, neuro, and breast. So that is partially to give the market enough time to mature. So every year when we come back, we have something new to talk about. And we'll also be spicing in some special topics lectures, including AI bias, AI and the user interface, and the changing role of AI in healthcare. And something else that's new about this year, we are very proud to partner with SABI, Society of Advanced Body Imaging. We are very grateful for this opportunity to get to bring this course to an even larger audience, to learners throughout the United States and internationally. And there are a lot of new opportunities that are going to come through this partnership that we're going to bring to our learners. And with that, I'm going to pass that off to Morgan Cox, who can give a little bit more detail about SABI and its benefits.
Thank you, Dr. Perchik. And on behalf of SABI, we are thrilled to partner with you for this AI literacy course. And we invite you, the audience, to join SABI, where we provide a vibrant community dedicated to advancing your career through cutting-edge education, mentorship opportunities, and access to the latest research in body imaging. With our resources, networking events, and upcoming annual conference, you'll gain valuable insights, collaborate with peers, and stay at the forefront of radiological advancements. Medical students, residents, and physicians currently in a fellowship training program do qualify for complimentary member in training membership. Thanks, Dr. Perchik.
All right, well, we're going to keep on rolling here. So with this first session today, I'm going to be giving a bit of an overview of the course. We're going to do an introduction of some of the fundamental AI terms and methods that we're going to be discussing and circling back to over the course of the week. And we're also going to close by talking about some of the basic concepts and statistics and data preparation that are important for AI training. So for this course, we're going to have 10 lectures over the course of the week. We're going to start with this introductory session. We're going to move into our special topics and our subspecialty applications. And we're also going to have a pre and post course evaluation. So all of you that register for the course, you should have gotten an email with the pre-course survey. This information is really important to us as we continue to try to improve this educational session, make sure that this is relevant to our learners. So if you have not done this, or if you've not completed this survey already, we ask you to do that before the end of the day today. And that information is really helpful for us as we continue to try to make sure that this course is relevant to our learners. So what we're looking to do is we want to provide accessible and clinically relevant information to radiologists when it comes to the use of AI in clinical practice. And so a big part of that is that we want to demonstrate not only the strengths of AI, but also the weaknesses of AI. So you can see where AI fails and where you as the expert user have to be able to override the result and ensure that the AI is not causing harm to your patients. So we're going to be providing a foundational knowledge and experience for you to be able to recognize the strengths and weaknesses of AI, to use it in your clinical practice, but also to hopefully give you the tools that you can be a leader when it comes to AI in your healthcare system. that as AI is being rolled out and being deployed in other clinical specialties, all these other clinical specialties are going to be looking to us in radiology because we have a decade-long head start at this point with applying AI into clinical practice. So being able to have this foundational knowledge will help you to be able to be the expert in the room and hopefully make you an invaluable part of the team in the future of AI in healthcare. Something new that we'll be doing this year, which is very exciting, is we'll be having a session at SABI. This is will be called Too Cool for School. This is going to be an AI roundtable where we'll be discussing different topics in radiology AI. And we're also going to be having a hands-on session with some of our AI vendors. Currently, this is only going to be for in-person attendees at SABI. Hopefully, in future years, we're going to be able to make this available to our remote attendees as well. So if you will, or if you are planning to be in person at SABI this year, which is going to be in DC starting on Saturday, we hope to see you at this Too Cool for School session. And so I think it is important for us to talk about what this course is and what it is not. So this course is meant to be an introduction. So this is an introduction and to build a foundational knowledge of AI. This course is not a computer science course. We're not going to be talking about coding, programming. It is not a statistics course. We will talk about some statistics at the end of this presentation, but this is in no way a deep dive and is certainly not an infallible look into the future of radiology and AI. So keys to having a successful course. As you're going through these lectures, I want you to focus on the basics. You should be able to learn these core concepts and apply them to the different subspecialties and different special topics that we're discussing, and concentrate on the practical applications. So think about how these will be applied in your clinical practice. So with that, we're going to get into the introduction of our AI terms and methods. So what we have here, these are our 10 core concepts of radiology AI. And, this is our 5th year doing this course. So as we've gone through, we've kind of honed down our curriculum to really focus on these 10 areas that we feel like are really fundamental to being able to have a good understanding of AI and radiology. So we're going to be going through these one by one. To start off, we have the AI terms hierarchy. So when we talk about artificial intelligence, AI, this is broadly just referring to computer systems that are able to perform tasks that traditionally would be thought to require human learning and human reasoning. This is kind of a catch-all term and refers to a lot of different methods and techniques in AI and in computer sciences. Machine learning is a technique that is used or that can be used to learn and adjust to tasks. Getting more advanced, we get into neural networks and deep learning, and these use different hidden layers to be able to mirror how humans make their decisions. So when we talk about AI, it's a catch-all term that refers to any derivation of these different techniques. So when we are training an AI application, there are different ways that we divide up our data. So we have our training set, our testing set, and our validation set. When you are splitting up your data, the vast majority of your data is going to go to the training set. And that kind of makes sense, right? That you're wanting to give your algorithm an exposure to a large amount of information so it's able to build strong connections and be able to handle challenges when new data is presented. So as an example of how this would be split up, if we were doing this in a training, testing, and validation set, we would do 60% in the training set, 20% testing, 20% validation. If we were only doing training and testing, then we could do 80% in training, 20% in testing. But that's just to say that the majority of your data is going to go to the training data set. And so to dive into these a little bit further, when we talk about training, that's going to be the data that's used so that the algorithm is able to develop so that we're able to develop the algorithm and form those patterns. The testing step is going to be the next step where we have separated this data off. We are then, after the algorithm has been trained, we expose it to this new set of data that we're able to see how it performs outside of its training data set. This is where we would see if it looks like it does not have as good of a performance as we would like, if it's not detecting positives that we know are positive, or if it's flagging more negatives than we would like to see. We might say, okay, well, we're going to need to go back. We're going to need to change our method in some way. Maybe we need to add more training data. But this is to say that this is the step that you would be able to go back and go from training to testing, and then perhaps back to retraining, retesting, retraining, retesting. And then once you have performance at a level that you're happy with, you can go to the validation stage, which is another set of data that you see how the algorithm is performing at a different step with new data. And an important step with, or another important subtype of validation is external validation. So that is where you have an algorithm that's been developed and it's been tested and it's been validated, but you take data from outside of the institution where this was trained. It might be tested on data from a different hospital, maybe a different region, maybe an international cohort of data. But this is to see if an algorithm performs as well in your own limited environment as it would out in the general population. And so when we talk about how well an application performs in the general population, we can talk about overfitting and underfitting. So overfitting is when you have an algorithm that is trained, tested, validated, perhaps within a single institution or a small cohort of institutions, and it does really well on those small sample sizes or that limited scope. But when it gets out into the general population, it doesn't perform as well. So that's saying that this algorithm has been overfitted to its training data. So it does really, really well at the place it was trained, but it might not do as well on data from outside of its training institution. And then on the other side, you have underfitting. So this would be saying that an algorithm, even at its own institution, the place that it's trained, it's still not performing well. And this would be something that you might observe during the testing phase, that you have underfitting, the algorithm is not performing well. So you need to go back and you need to do some retraining. Maybe you need to try a different method or add some more training data. And then taking a step further, algorithm bias is one of the pitfalls of the application of clinical AI. This is where an algorithm might make these patterns and might make decisions that result in a biased outcome. So you may have an algorithm that performs worse on certain patient populations, worse on exams that are done in certain locations, or on certain scanners, but you end up with this differential result that is not working as well for certain patient populations. So this can be a result of insufficient diversity in the AI development stages. So in the training data, and one of the phrases that we like to use to explain this is that an algorithm is only as good as its data, or to say it another way, that biased data results in a biased algorithm. So this can be very hard to detect, especially when you're at the deployment stage and you're using this on a very large number of people. This is something that it's very difficult to detect, and it can result in real patient harm for some of these high stakes algorithms that are making decisions that affect patient treatment. So just to help you visualize what this can look like. So hypothetically, we have a pretend cardiomegaly algorithm here, and if you can imagine that, perhaps this was trained at a hospital system on the left where they had a predominance of male patients, and then this algorithm was deployed, and we noticed that it's having a disproportionately higher number of false positives on female patients, just because they weren't as represented in the training phases. And in your mind, you could think of several reasons for why that could be the case. Maybe this is maybe it's including breast tissue in the calculation. Maybe there's other just hidden aspects of the image that are causing this biased result. But because this is disproportionately affecting female patients compared to male patients, this would be an example of algorithm bias. So when we talk about supervised and unsupervised learning, this is how we are this is how we train the algorithm. So with supervised learning, this is where you have human oversight, and the human user is who determines the ground truth. So an example of this would be for anatomy segmentation, that you might have a human user who traces out a lesion or an organ, and the algorithm is learning based off of what the human user is telling it is the ground truth. And then on the other hand, you have unsupervised learning, which does not require a human user. This is where the algorithm is organizing data, extracting features, determining patterns autonomously, and does not require human oversight. And then in the middle, you have semi-supervised learning, where you have the step where the algorithm is extracting data and determining patterns, but at some point in the process, the human user is able to provide feedback and help to determine the ground truth. So here we have a fun graphical representation of what this can look like. So in supervised learning, you have the human user that is providing oversight to the algorithm. In unsupervised learning, this is a more autonomous process with the algorithm detecting patterns and learning on its own. In the supervised or semi-supervised learning, the human user is able to give feedback during the algorithm development. And so it's also important to remember that in radiology AI, not all AI is related directly to image interpretation. So a lot of us would probably think of, or if we think about radiology AI, we might think about a pneumonia detecting algorithm, or maybe a brain hemorrhage detecting algorithm. But really the majority of AI applications in radiology are non-interpretive. So we can talk about these non-interpretive applications or the medical image management applications as being either upstream or downstream. So upstream applications would be prior to image interpretation. So these could be image processing applications that give you a higher quality image with less data. They could even be more upstream, where it's a clinician decision support software that helps the clinicians order the appropriate study. And then downstream AI would be after image acquisition and interpretation. And these could be 3D reconstructions for surgery planning, and they could also be your natural language processing tools that flag certain reports for aortic aneurysms or other findings. And so generalizability, this is the opposite of overfitting. So an algorithm that's generalizable is one that does as well in the general population as it does on its training data set. So this is what vendors are really looking to accomplish when they are developing their AI applications. They want something that's going to do as well in Birmingham, Alabama, as it's going to do in Atlanta, Georgia, as it will in New York City, London, Dubai, anywhere else throughout the world on any patient population. There are challenges in generalizability. Like we were talking about, algorithm bias can be very difficult to screen for and detect once you're in the clinical deployment stage. And also over time, it's just expected that algorithms won't perform as well for a number of reasons, but this degrading performance over time is called algorithm drift. So when you want a generalizable algorithm, this is when you want a high diversity in your training data, so that the algorithm is going to be able to perform well when it's challenged with new types of data that it has not seen before. So again, as a graphical representation of this, we have the cardiomegaly application that was trained at Hospital A. But this was given a much wider range and diverse data. So not only is this performing well at Hospital A, but we have hospitals B and C that have different patient populations, and the algorithm is still performing well. So we would say that this is a generalizable AI application. So another pitfall for clinical AI application is the AI black box. So in the medical field, we're making very high stakes diagnoses. And when we're feeding these applications, and we have different applications for cancer detection, for pneumothorax, for brain aneurysm, brain hemorrhage, these all set our patients down a treatment pathway that can be very, very high stakes. And if we are using AI assistance in that, we need to be able to understand why the AI is making these decisions. So if we have just an image from a chest CT on the top right here. This goes into the algorithm, and for some reason, the algorithm spits out a diagnosis of this patient is high risk for cancer. I wouldn't be able to look at this with my simple human eyes and be able to tell you why, in this case, on this image, the AI is flagging this as high risk for cancer. So having explainability is the ability of an AI application to be able to highlight parts of the image that it deems as highly suspicious. So one of the features that is common or to accomplish this would be heat maps. So you can have an overlay that would direct your eye to where in the image is deemed most suspicious, and this provides a level of explainability, which is very important to overcoming that AI black box. And so as an example of that, so we have a CT or an image from a CT head on the left. Top right, we have a CT chest with contrast, and bottom right, we have a breast MRI. And these heat maps are directing the user's attention to an area that was suspicious for intracranial hemorrhage, pulmonary embolus, and non-mass enhancement, respectively. So the vast majority of AI applications that are in the marketplace today are very narrow in scope. So when we talk about narrow AI, that's saying that these applications function often on a single modality and may only function for a single pathology. So if we have a pneumothorax detecting application that works for a chest radiograph, we would not expect this to also detect pleural effusion. We would not expect it to detect pneumonia, and we would also not expect it to detect pneumothorax on a chest CT. So this is performing a single task on a single modality. So the fear or the anxiety of a what you could call a fellow in a box of an AI application that's able to be plugged in and can give you a full report, differential diagnosis, follow-up recommendations on any exam is a far cry from the reality that we have today. That would be a more generalized AI, but the tools that we have in practice are much more narrow, and all of these require human oversight. And then the last topic that we cover in these terms and methods introduction is radiomics. I won't get too far into this because we're going to be having a very good lecture on Wednesday from Dr. Manoj Tanwar with an introduction to radiomics. But this is, very briefly, it's an advanced method in AI that uses feature extraction and pattern recognition to see beyond what the human eye is able to see. It's been referred to as a virtual biopsy, that you're able to get pathologic data, maybe even prognostication data, treatment recommendations for different pathologies based on imaging features that the human eye is just not able to determine. This is a very exciting area of AI, but this is really pretty much limited to the research, or limited to the research realm at this point, because there's high risks of overfitting. There's challenges in getting a generalizable tool like this, but these have been highly researched and will likely be entering the AI marketplace sooner rather than later. And this is just an example of what these articles can look like, that you can see how they visualize how the AI is detecting these patterns and texture features and making its decisions. And so those are the 10 core concepts of clinical AI. We'll be circling back to these over the course of the week. This is just meant to, again, lay a foundation so that you'll recognize some of these terms and some of these concepts as you see the different special topics lectures and subspecialty lectures. And we will close my session out with an introduction of some of the common statistics and some concepts of data preparation. So this will be a very cursory level discussion on statistics. I do not consider myself a statistics master, but these are some very important and very common ones that you'll see when we talk about, or when you see AI papers and when you see some of the data that different vendors will present about their products. So to start off, we have the AUC ROC curve. So this is plotting sensitivity versus specificity. And when you're looking at a graph like this, you're wanting to see a curve that is close to a right angle up across the top. So this would give you a value closer to 1. So values closer to 1.0 are perfect sensitivity and specificity. And as you get closer to 0.5, that's going to be your linear slope here, and that would be essentially a flip of a coin. So the way that you might see these presented is you might see different lines that you would say, oh, this is the performance of the AI alone. This is the performance of the AI plus or if this is the performance of the human user, and this is the performance of the AI plus the human user. So the closer that you get to this 1.0 area under the curve, the higher their performance. And similarly, we have the dice coefficient. This is used for your segmentation tools. This is comparing the performance of a automatic segmentation to the ground truth. Maybe you have a tracing that was done by a human user, and then you compare the overlap of that to the automated tracing that was done by a computer program. And so you take the overlap of those two tracings, you multiply that by 2, and then you divide that by the sum of the two tracings. So again, you want a value that's closer to 1.0. The closer that you get to 0, then that means that there was little or no overlap. And then this matrix over here on the right might look familiar to a lot of you who have been, if you've done board prep recently, or if you're prepping for boards coming up this year. This is the confusion matrix that's plotting your true positives, false negatives, true negatives. And some of the more common statistics that you'll see from here will be recall, which is another word for sensitivity, precision, which is positive predictive value, and accuracy. So as a very brief review, when we say something has a high recall or a high sensitivity, that means it's very sensitive to positive findings. So you're going to detect a high proportion of the positive findings, but potentially at the risk of having a higher number of false positives. High precision, on the other hand, is going to give you a high likelihood that a positive value is truly positive. But it is possible that the false negatives, or this could have a high precision but higher false negatives. And then finally, high accuracy is going to evaluate both your true positives and your true negatives compared to the total number of cases. So a highly accurate algorithm is going to be is likely to be correct both for true and or for positive and negative values. And so like we've been saying, for data preparation, you want a wide variety of data. So you want diversity in study population, but also a variety in different types of machines where these images are acquired. You want different imaging techniques. You want high quality and low quality images. And this is to make sure that your algorithm is robust, it is generalizable, it's able to handle when it's challenged with different types of imaging data and different patient populations. So when we're talking about sample size, a lot of algorithms that we see described in the literature, these are proof of concept papers. They're not necessarily trying to make an algorithm that's going to go into deployment or be submitted for FDA clearance. So for these smaller, more proof of concept papers, you might have sample sizes in the hundreds, maybe low thousands. But for commercial tools, you really need sample sizes in the tens of thousands, hundreds of thousands, maybe millions of cases to have adequate training. And this can be very challenging to acquire that scale of anonymized data. So something that can be done is data augmentation. That's where you can take exam images, you can flip them, you can add blurring filters, grids, downscaling, and just to show how this can be valuable. So going from a single image that you have on the left, you can alter this in different ways to augment your data from a single exam to 5, 10, 15 different images that are able to be used for algorithm training. And then a key concern with patient images is ensuring patient privacy. So when we have these images that are used for data or for algorithm training, we have to be sure to scrub the DICOM header. We remove any patient identifiers, which include name, date of birth, accession number on the exam. But we also have to be considerate of other patient identifying information, which on head CTs and face or on head MRIs, we have to be considerate of 3D facial reconstructions, which can be identifying for patients as well. So that is a very rapid introduction to the core concepts of clinical AI and some of the concepts of data preparation. I'm very excited that we're going to get to kick off a very, very full week. And I know that I am also at the end of my time here. So I'll be happy to take questions at the end of our day today. But without further delay, I will kick it off to Dr. Rainey, who's going to present the topic on AI and the user experience.